Yeah. And interesting, she is a physical therapist as well as a German major. I don't hear that very often. Tell us, why did you get that and how?
So it's an interesting story. It turns out to be not as interesting to other people as I find it myself, I think. But in college, I started off as a biology major because I knew I wanted to go into the medical field. And after a couple
Hmm.
of semesters of straight science classes, I decided lab work is not for me. I'm not into titrating things in petri dishes for hours on end. But I really liked the human aspect, and I loved learning the biology, and I loved the anatomy classes, and all of the other things for prerequisites to attend a physical therapy program fit me. At the time, I had chosen to do a minor in German language and literature because my family history includes a long lineage of people from Germany and Scandinavia. So I thought that might be an interesting thing to learn more about. And then I took the opportunity to study abroad, and I loved it so much in Germany that I applied for a scholarship and went back for more.
Sounds
And
like fun.
I just talked to a counselor, an academic advisor, and we decided it would be possible for me to
Hmm.
switch my major and still satisfy my graduate school requisite. So that's what I did. I studied German literature, and I got a husband out of the deal. I met my husband abroad.
Well, that is awesome. I hope that's a side effect, right? From learning a new language.
Yeah.
Well, that's cool. Amazing. Has it helped you somewhat in your practice in real life? I was
I
curious.
think in general, it was a leg up in my application process to graduate school because physical therapy is definitely a blend of art and science, and you have to have a lot of people skills, and having some
Hmm.
knowledge of worlds outside of my own little bubble helped with that. Having perspective on how other people live, having mentally gone through the process of learning a second language as an adult, I think was also
Hmm.
important because it's different when you're bilingual and raised that way than when you have to put the deep work in and feel the brain hurt when you're studying vocabulary and trying to piece together grammar components.
Hmm.
And in the US, we're not trained very well in grammar, unfortunately. So
Really?
all of
I remember.
those skills, I think, helped my develop more of a critical thinking approach and analytical thinking approach. You had to apply that to language development and literature, of course. Literary analysis is also another way to reframe the way we approach things in the world if you look at it through the eyes of authors who lived generations before we did, for example. So yeah, I think all of it definitely boosted my way of thinking, and certainly changed the way that I approach people compared to someone who may have just focused on the science classes uh, before graduate school. That's my perspective anyway.
Okay, so what will you be doing at the San Diego Pain Summit? What will you present?
My topic for the San Diego Pain Summit in 2019 is all about pain assessment from the patient perspective. And the title, in part, reads, I'm not a number. So learning that it was,
Number.
yeah, the idea was prompted pretty directly from the patient panel that was organized last year at the 2018 Pain Summit. And it hit home a topic that I had been struggling with as a clinician for a long time and had been trying to promote some change in my colleagues for quite a while, but never felt any movement or enthusiasm, got a lot of resistance. And that is the use of the 0 to 10 scale to rate your pain, being asked about it all the time. And it truly loses its meaning in persistent pain. It's not always appreciated in acute pain situations either. I think it's just a complete way to gauge what somebody is struggling with. And the extreme end of that is when people don't feel believed because they say my pain is off the scale, 12 out of 10. And of course, that can set them up to feel stigmatized or judged by clinicians who think they're just exaggerating or can't possibly experience pain higher than a 10 when the scale goes to 10. It's been a frustration. My patients, and clinically, all I work with are people with complex pain conditions, long-standing pain, and they almost exclusively express frustration about that scale. And yet we in healthcare, for some reason, actually many reasons, which is what I'm going to talk about, feel obligated to continuously ask it. And it loses a lot of utility when you just drone on and give the same information that you've been asked about a dozen times before in the last year. So when I heard the panel of patients express their experience and their frustration, and to the extent of feeling they had to lie or misconstrue just to get insurance to pay for certain things. Otherwise, it really flipped everything on its head for me and made me realize that I have to take some action, get more vocal about this issue that I've been thinking about for a while. And thankfully, Rajan thought it was a good idea as well. I think there's a lot of room to make some changes, but not unless we all have a conversation about it and understand how we got where we are and what we truly could do to make some differences. And I think just pushing the needle a little bit further one direction can improve things in the long term. We may not feel those changes right away, but having venues like the San Diego Pain Summit is a really great opportunity and place to start.
Okay, that's cool. Well, looking forward to it, actually. Yeah, and also, how, given what you know about the biopsychosocial model of pain and health, so how do you apply that to your practice?
Well, I consider myself very lucky because I work in a truly interdisciplinary practice setting. Hi, Max. This is Max, everyone. I work in an outpatient hospital setting. I was hired under a national directive as part of the VA healthcare system. And the directive started in 2009, and its goal was to disseminate interdisciplinary care for chronic pain across the nation in all the hospital. So at the basic level, our expectation as clinicians was to build a program consistent with the biopsychosocial model. And because of that, that means I have teammates in different disciplines who also subscribe to that framework and model of care. And we work together to make sure that we are covering all the domains and teaching patients the interplay between those domains of sociological inputs and influences on our bodies and our nervous systems, and the psychological manifestations that may happen in our body, but certainly in the mind can trigger some changes in our body. And certainly there's so much crossover. We just never can separate the mind and the body, and nor should we try. That to me is the essence of the biopsychosocial model, and how it plays out for me at work is just seamless. I work directly across the hall from a psychologist who is a behavioral health expert. And we've had lots of conversations over the decade we've worked together in how to transition and get our language similar. We have the same messaging with the pharmacists, the physicians. I'm the only physical therapist on the team, but the primary care providers that we interact with, we get a lot of cohesion and unification in our messaging because of the clinical environment where I work. So I would say there's no better way to embody the biopsychosocial model of care within my workplace. Like I say, I'm really lucky.
That's good. Well, so how do they take it? How do the other clinicians, do they also have a similar perspective as you do?
It's evolved. Okay. Psychologists, as part of their basic training, definitely have that biopsychosocial approach built in. We now work with an occupational therapist too. She's on our team. She teaches mindfulness. And occupational therapy in their formal education get quite a bit more of the biopsychosocial framework built in. It's not the case for interventionalists or anesthesiologists or surgeons. That much is true. And so there has been a concerted effort on my part, my psychology colleagues' part, to slowly and steadily trickle in some different language and different ways to speak to patients to try to shift how our colleagues in medicine discuss pain, approach pain, conceptualize of persistent pain. And that has absolutely changed, but it is not a quick process. I will have to be honest there. I've been doing this for 10 years, and and it's better than it was, but it's now it's wonderful to walk into an office and hear a doctor say, well, your nervous system matters here too. We can talk about the needle injections, but actually, I think that's not going to be the most helpful for you right now. So there have been major transitions, but slow and steady, like a trickle or a drop. One drop in a bucket doesn't feel like much, but it does add up. If you've ever had a leaky roof, you know what that's like. Yeah.
Well, San Diego, we don't get a lot of rain, so we don't have a lot of leaky roofs here. All right. Well, that sounds like a progress being made over and over there.
Yeah. Well, it is a process still, and I work with a number of different physicians. Some I have more direct interaction with than others, and they're still very biomechanically focused, and partly I think it's hard to dissect that out. It's hard to expect that to teach because I work in a teaching hospital that has a relationship with UCSF, so we have fellowship trainees in medicine whose job it is to come and learn how to stick needle in people safely. And so when your job is to learn that skill, you approach it from a theoretical framework that has to fit that goal, right? So it's hard to really get people away from what they're doing with their injection at that very focal site and how that maps onto the bigger picture. So my dream would be that the wait time for people getting into the procedure clinic is no longer 6 months and not backed up and full every week, but in fact, there are open slots and they can't fill the slots because ultimately that's a lesser part of the treatment plan for most people who have widespread or multi-site pain conditions. The data on injections is just not great. It has its place in our healthcare system, but as it is now, it's still a big place for learning. Where I work, there's no financial incentive to give more injections or do more surgeries, so I can't argue that. But teaching students how to execute procedures takes a lot of practice. So naturally, that's where their mental focus is for the time they're with us.
Well, that's good to know. Well, at least it's making slow progress rather than going backwards. Because sometimes when I go on social media, we look at a few things. It seems like there is still a huge number of manual therapists who still needs to catch up and be up to. So, wish we could have more like you.
Well, I am the first to tell you that what I say today might change 5 years from now. And what I used to tell patients 10 years ago was completely different from how I talk to patients about pain now. And I hope that everybody who cares about their own knowledge and their learning process is ready to reject things that don't make sense or subscribe to things that are now supported by research that weren't available before. But I know it's not that simple, and I do my best, but I also am full of biases. Everybody has a bias about something, so I just try to be honest with myself.
That's the way to do it. Hey, so one more question. Have you read all those books behind you?
No. So I married a man who was also a literature major. And
oh, sweet. Okay.
Yeah, if you want to see.
Oh my gosh. That is like, what's like
so many books on the floor. They're everywhere.
Oh my gosh. That is like the library where Sarah Haig
is it?
Home is. Have you seen her?
I've not seen it in its
full form. It looks just like yours.
Yeah. So I've not read all of them. Some of them are duplicate copies. The same book written in German and then the English translation or vice versa. So we have some duplicates. And some of them are, volumes, literary encyclopedia volumes, reference books, harking back to before the internet was available. So I cannot cop to reading all of them, but some of what you see are CDs too. So we still have some of that technology in our home.
Hey, so what do you look forward to next month? What do you look forward to?
Next month, specifically the Pain Summit, or generally?
For the Pain Summit, too.
Specifically, I'm looking forward to the San Diego Pain Summit. I'm excited to hear the other speakers, the keynote speaker. I'm curious to see how Mark is going to do at MC. and always the networking, talking to people, learning new things, getting perspectives challenged. That's the great thing about this venue, is there's a safe space to just discuss and learn and argue and support. And I think it's a tremendous opportunity to just get more information and get excited about what we do, because the truth is, working with pain, working with people who have pain, especially long-standing pain with a lot of effects, debilitating effects on their social lives and their work lives and their identity, all of that, it's very difficult work. And burnout rates are high. And so places like the San Diego Pain Summit provide people who do that work with an opportunity to rejuvenate themselves, get excited again about the kind of things that we do. And I think it's really important. Yeah.
Well, that is awesome. I feel you. Every year it's like that. Once I'm done, I feel like I need to want to spew out all this information to all my clients or people that I work with, but it doesn't happen that way. It just gotta be like,
well, and that's what exactly. Right after I left that panel discussion, I was jotting down information, jotting down some notes to myself to build an outline for a talk about pain assessment and the verbal analog scale, or the visual analog scale, the numeric rating scale for pain. Because all of a sudden, these thoughts that I'd had and these complaints that I had internally been grappling with, I decided I have to take some action at work. And I am the chair of the pain committee for our hospital system. And so the very next week, we had our bi-monthly meeting, and I came back from the conference and I was so excited. And I said, okay, people, we got to figure out a way to make this change. And I might talk a little more about that experience when I'm on stage in February.
Definitely.
But the reality is, enthusiasm is one thing, but changing processes and operationalizing something in a big hospital or healthcare system, that's a whole other thing, which is exactly why we need to get more people knowledgeable, understanding how we got to where we are, so that we can take some real meaningful action to make some change collectively. Because on a systems level, you have to take stepwise approaches and get a lot of people involved in order to make any shift.
It makes sense. Well, thank you, Katie. That's all the time we have currently, and looking forward to pick your brain a little bit, listen to your talk, and as well as kind of hang out